So I had to write on the sheet that he hangs out with his grandmother that smokes medicinal marijuana. And then when I got back from the lab, they were surprised that he walked into the appointment because he was that stoned that they don't know how he got there.
If you're doing a good job, chances are people are going to come back anyways.
Movement is key to getting better. Don't sit around and do nothing. Don't put a cast on it when you need to be moving the limb or whatever it is. It's like taking one Panadol and then blaming your doctor it doesn't work, and they might say, well, I told you to take 2 in the morning, 2 at night. But that's not a normal thing on like Medicare. It's not a normal thing on the public health sector. But we need to work on returning to life first, and then you can focus on all the other noise.
So my jaw's just dropped. Half their workers.
Yeah, easily. And if there's an accident that's going to happen on site as a consequence, or an oversight, then it's like you're liable personally. But I feel like it's not a hard ask to tell someone, hey, just don't be on drugs while you're at work.
Don't do drugs.
Yeah,
Basically,
absolutely.
just don't do drugs.
Yeah.
Before we begin, can I have a minute of your time? In Australia, every few minutes, someone gets injured at work, on a work site, in a warehouse, on the road, and in an office chair that they've sat in for over 10 years. And most of these injuries, they were preventable. Our podcast exists for one reason: to have an open conversation about work, safety, and our compensation system. We talk to experts in our field to discuss the good, the broken, and what to improve within the system. Because safety isn't paperwork, it's people, it's the family, it's our future. So if you learn something new from this episode, make sure you subscribe to the AusRehab podcast. And if you or someone you know has a powerful story about injury, recovery, workplace safety, or any related topics, reach out to us. We're always open to guests who move this conversation forward in Australia. Now, let's get into today's episode. Welcome to the next episode of AusRehab podcast. Today we've got a new guest, John Beshay. He's the owner of Empire Rehab. Does EP,
Chiro.
EP treatment,
Yeah.
Chiro as well.
Yeah.
And I'm very sure you said you do
Rehab.
Rehab as well on the side.
consultant.
Yeah. So I don't know. For the audience, let's 2-3 minutes of introduction of yourself.
Sure. So my story, I tend to follow like trends that are going through the family. So I, like many other people, studied my Bachelor's of Exercise and Sports Science in the intentions of doing something like physiotherapy. Like a lot of students did that. They started off with EP and then they went into like physio or something else. So I started off that way. But then my brother actually ended up on a workers' comp claim. He hurt his back at work and he went and saw chiros, physios, osteos. No one helped, and then he eventually saw an EP and they ended up fixing him. So I'm like, wow, there's some truth to this. Like I should dig deeper. So I ended up doing a master's in rehab, like following my passion because I wanted to help him. So some people did like strength and conditioning. I ended up going into the rehab sector. So at the beginning, I focused on like cardiovascular rehab, but since then I've gone into like autoimmune and neurological rehab. So like most of my patients have like MS, Parkinson's, stroke patients. And it's incredible. Like it's like that saying that if you love your job, you don't work a day in your life kind of thing.
Oh, wow.
So I absolutely love it. And then from that, I was obsessed with go-karting, like completely obsessed, like the size of me, and I was still beating my mates that are like half the size.
Dude, like what do you mean? Like go-kart's supposed to be, the lighter it is, the better it is. You look like, 100.
Maybe I tuned the go-karts. No, I'm a bit above that.
Bit above that, okay.
Yeah. So I was obsessed with go-karting. And one of my mates thought it would be funny to hit me at full speed when I stopped. And so typical whiplash, like my head went forward, snapped back. I thought, okay, there's a bit of pain in my neck. This is going to be interesting. Next day I felt fine. And then the day after that I was moving, like we had these barriers at work to block the cars in. So I lifted one, like a witch's hat, lifted it up. It was only like a kilo. And then I felt and heard every segment in my back just crack, like one after the other. And then my neck was completely locked. Wow. And it was like the most horrendous pain I've ever been in, like by far.
How long ago was this?
Probably around 10 years ago.
10 years ago, okay.
And then, so me, myself, like I didn't have the knowledge to know what was happening because there was no position I could get comfortable in. Like it was completely like textbook. And then eventually I went and saw a chiro and he fixed it. And it's like I could breathe again. Like I just felt like this nerve release and it was like my chest was really tight. And then I'm like, this is crazy. I thought it was all BS, like the chiropractic approach.
Well, yeah, no, I think the common perception is that, it fixes you for one day and then the next day it doesn't work.
So that's where, like long story short, it ended up getting me to do chiro because I was that influenced by him, and I was that like he was just an idol, like still is. Like I respect like professionals big time, especially.
What's his name? I think if someone has a spinal injury, go and find him.
He's from Sydney Health and Sports Clinic in South Wentworthville, Mohammed.
Okay.
So he's incredible. He's really good with his hands and everything, and headache treatment and migraines and stuff like that. So ended up, he got me, like he influenced me. So I ended up studying chiro. It was so difficult. Just the degree, the politics behind it, everything else. And then with my background of EP, like I clashed a lot with some of my teachers and stuff because they'd want me to adjust a patient and I'm like, but I could just do a muscle release. Like I could just get them to do an exercise for it. So it didn't align with everyone's sort of thoughts for it. But I think combining both the EP and the chiro is awesome because if someone's potentially in pain, or if someone's not appropriate to be adjusted, it's not like that's the only tool in my shed. I can easily do rehab for them, get them to do exercises. So what like I enjoy about potentially my journey is that I've been affected by injury. I've been affected by like politics in the health industry, and especially being an EP, generally we're seen as being like lower in the food chain. And
yeah, it's very unfortunate, but that I think that is a common perception as well. Like for everyone that doesn't know, like EP is exercise physiologist. You guys go through a hell of a lot of studying.
Yeah.
And then people essentially say that you're not as good as a physio or something. I personally think it's the person, not the degree.
Yeah.
But still, unfortunately, there's a stigma that says EPs are not as well. Me personally,
See, I think like it depends on what your scope is. So like if you've got physios, chiros, osteos, podiatrists, whatever, like the acute practitioners, we can assume they're going to be excellent at acute and subacute management. Then when you've got an EP, they're going to be fantastic at subacute and chronic management. It's a completely different ballgame when someone's in chronic pain to when they're in acute pain. But if we're going to relate this back to the workers' comp situation, then when someone's in that chronic stages of pain and then they feel like it's whinging their back, so this is like part of that return to work process. So a lot of people don't want to go back to work because they feel like they might trigger their injury again. When they have another relapse of their injury, the body has no idea what's happened. So the body's going to treat that as if it's an acute injury again, and then the inflammation process starts again. So that's where the EP sort of has to be across a few different sectors with how to manage that. Because if the claim, and it's fine, it can happen, but if the claim goes back to physio and they're just going to do heat packs for another 2 years, that's potentially not going to benefit the patient. But like you said, it's definitely the practitioner. Like you can have good and bad in every bunch. And I feel like with physiotherapists, they should be king. Like their skill set is so enormous that a lot of them will like start using things like heat packs and like dry needling and stuff like that, where it's like you could help someone walk again. You could help someone like really return to life. But some of them just don't see the motivation in it. And I feel like that might be an industry standard, that the pressures are so high that they feel like they don't need to sort of work towards it. Don't have the answers. Like it's easy to pick apart problems without the solutions.
It is. It's usually easy to pick apart problems when you're not part of it as well.
Yeah,
As in, like,
absolutely.
You're bad,
Yeah.
but I don't know how to do it. Yeah. But okay, so what's actually the difference between a chiro and an EP?
So with like, I think the modern chiro is different to the chiros that are like 10, 20 years ago out of uni. So I think in general anyway, once you've got an acute practitioner or a diagnostician, once they're 5, 10 years out of uni, I feel like they overlap. So this is including physios, osteos, chiros. They're generally going to do what works for the patients and what they've had results with. So that's where you've got physios that do adjustments. That's where you've got like chiros that do rehab. Like 20 years ago, it wasn't really a thing. Like a chiro would potentially tell you, take anti-inflammatory while I adjust you, and we'll see how we go with a scope of 2 or 3 sessions a week. But now I think people in general, the way the health industry is moving is that you have to be holistic. But that has its own problems where if you're holistic, then your scope is perceived as being so large that you're potentially never going to hand over a patient to someone like an EP, or you're never going to, like a chiro would generally take the patient from 100, well, 0%, let's say, to 100, and they'll have the patient the whole time. Whereas like the strengthening component, it's like it's potentially not even touched yet, where everyone knows evidence-based practice is that you need a strengthening component in. So normally acute injury, you're restoring motion, you're ideally reducing pain, but pain's not the only barrier. And then the chronic management would be to strengthen the patient so that the problem doesn't come back. So without that strengthening and the rehab side of it, like I would never be confident with one of my patients if I adjust them. I'm all about the placebo effect. And with my personal patients, I tell them, hey, you feel fantastic now, but just give it a couple of hours. That's why you need to do the exercises that I've given you as well. Even my chiro patients, I'm like, hey, you need to do rehab. Otherwise this won't stick. It's like taking one Panadol and then blaming your doctor it doesn't work. And they might say, well, I told you to take 2 in the morning, 2 at night. Like you haven't followed the scope. So with this sort of stuff, it touches on that too.
Do you think being a chiro and an EP actually helps, like as in yourself being both a chiro and an EP, does it help patients more than just being an EP by itself?
Definitely, like it helps in terms of like, so there's a few patients that I've got at the moment, workers' comp, and their case managers and the IMSs have actually, once they found out I'm a chiro, they're like, hey, John, why don't you treat this patient as a chiro? Because I've had a lot of barriers as EP because like the doctor's maybe not listening to my diagnosis because EPs generally can't diagnose. But if you've seen like a frozen shoulder 50 times or 100 times or 1,000 times, chances are you're going to be good at spotting it. But in the way the system's set, which is fine, but EPs can't diagnose and you can almost not even talk about it because no one will take you seriously. But with the chiro component, if I send a letter to a doctor and just call myself Dr. John Beshay /chiro, they take it a lot more seriously and they actually take my diagnosis into the certificate of capacity. So that's sort of never happened before. So it's an amazing feeling because I'm doing the orthopedic tests, I'm doing x-rays potentially because I can refer them myself, that sort of thing. And I've even had, but this is like so rare, but I've had case managers tell me that if I want an MRI, just let them know and they will approve it for me. So that's not a normal thing on like Medicare. It's not a normal thing on the public health sector, but I think they're starting to understand the scopes of different practitioners in the schemes and people are going to have strengths in certain areas. And I think with chiros, diagnostically, they're fantastic. Physios can definitely be there, but a lot of them, like I think you had a doctor on earlier who mentioned the working diagnosis. And it's a shame that doesn't, it should be a variable. Like it should be, okay, cool, we started off here with like a grade 3 supraspinatus tear, but now, of course, over time, it's turned into a grade 2 and then a grade 1. But that certificate in 2 years' time is still going to have grade 3 tear. So it doesn't change. But then if you're putting yourself in the shoes of an IMS or a case manager, they want to see progression, even if that means the diagnosis, because that means something's happening. But if that person has been stuck at 0 capacity and there's no objective data that's changed, why would they keep paying for treatment? Why wouldn't they just go to a work cap decision, which unfortunately or fortunately, a lot of injured workers end up going down the path of. But yeah, in terms of with treatment modalities, I think with like when I was an EP, I felt like they gave me a book and they said, hey, have fun reading it. And you get halfway and they're like, that's enough. Like you don't need to read the rest. And I'm like, it's just gotten interesting. So then with the chiro component, I feel like that's where the rest of the book has shown itself because you can sort of like sky's the limit when you're a diagnostician or you're an acute practitioner because like there's no one necessarily stopping you and you can just keep focusing on different areas and different pathways. Whereas with EP, like I had IPC, like independent physio, they'd call me and like, because I'm not junior. So they would try the junior techniques on me by trying to bully me to sign off or discharge a patient.
That's actually very normal as well.
Absolutely.
Like very normal.
Yeah. So now given the extra chiro qualification, they don't push me around as much. But even before chiro, like once I was like, I think you can tell with most practitioners if they're sort of in their domain. So like you can tell if someone either doesn't know what they're talking about, and it's just ironic that we're doing this, but you can also tell, like I feel like most layman people kind of thing, if they go see a chiro and that chiro is hurting them or something, they will be able to say, oh, maybe this chiro wasn't for me. Like it's not a rocket science kind of thing. But then when you go see potentially a chiro or a physio or whoever, and they know what they're doing and they know how to, like they know exactly where the pain's coming from, they've sort of pulled you apart in their heads and they're trying to like show you what's going on, like the mechanism of injury and what the compensatory mechanisms are, and they make it make sense. Then having that education for the patient, it makes so much of a difference. The patient will be more willing to take your requests and do your program and be compliant with the sessions, that sort of thing, and then just follow what your guidance is.
No, I see the benefits. You know, what you're saying is essentially you have both knowledge. You have knowledge in both spheres of practice. But question that I do have is, you know, like the incentive of being an EP now is probably very low because they get paid a lot less than chiros, right?
Yeah.
Like I don't know the actual numbers, but I think chiros like 210, 220 per hour.
Like around that.
And then EP's like what, 90?
With EP, it's basically
$90?
because they've split EP up into minor injury and complex.
Yeah.
Whereas physios, chiros, whatever, you've got the like the middle ground of like the code is B. So you've got A and C for EP. You don't have B.
Yeah. So you know, what's your incentive to actually, you know, keep training EPs and not just focused entirely on chiro?
Well, so one of the reasons I guess that I did chiro is because I'd get a referral from like, let's say a physio, and it's potentially like, I call it like a hostile referral because the insurer's been like, hey, no more physio. And I'm like, this person,
10 or something, or 20 or something like that.
So this, or like they've treated the patient 100 times, like whatever. But it like used to frustrate me that with the expectation of the practitioner, like with physios, and I used to like manage like allied health and stuff, and you'd see their treatment requests. And with the EP one, which now they're called allied health treatment requests, before they were allied health.
AHR, now it's like ATHR or something.
Yeah, so it was the AHRR.
Yeah.
With the AHRR, I feel like that was in a weird way a lot more superior than the current standard because you'd actually be able to justify why you needed the treatment.
Really?
So as EPs, we were told to put evidence in there. Yeah. So we'd actually like use articles and stuff in that last little bit saying like, why do you need the treatment? But then physios would just write something simple because they could, saying to assist with return to work. Like that was it, where I've put like paragraphs of information saying that this is where they're at in the inflammatory stage, this is where we need them to be. So you end up painting a picture for the case manager, because 10 years ago, it was rare for a case manager to have a medical background. Nowadays, though, it's pretty common that they're chiros, they're EPs, they're whatever.
Really? Yeah. Case managers? I actually didn't know this, because I think, you know, on the ads of case managers, it still is, there's no require for any tertiary health background at all.
Yeah, but it's a definite positive for them, especially when we're discussing claims and stuff, and you don't have to break it down as much as you may have used to have to. So I think it's a good progression that it's getting with the times. And then the IMSs obviously have, like you would hope anyway, that they've got sufficient experience as well to focus on like back injuries. But with like with the IPCs that I've dealt with, like one of my mentors when I was younger in my career, he used to tell me that if you've ever got an issue with getting approvals, then as a practitioner, tick that you want an independent consultant. So I used to always tick it. Very rarely the case manager would actually, because they're backlogged, like the IPCs, like good luck getting one in 6 months. So I used to trigger the IPC process. And when they'd call me, they would assume that it was the case manager that got them. So like I was in trouble. But I'm like, no, I'm the one that wanted to talk to you about this claim. And then I guess in my more like senior years, like I would know the background of most of the IPCs, and it's like, well, this one's a hand therapist and he's talking to me about a lower back injury. How does that work when potentially he doesn't, like in that situation, I've potentially got more experience than they do. And
can I ask, did you do the EP first, or did you do rehab, rehab first?
So, well, I became an EP first, and then I always wanted to do treatment. I never wanted to do OcRehab because I thought being like a rehab provider or a rehab consultant, you worked for the insurer. In my junior years, like there was nothing to change my mind. Like I just despised it. Like I didn't enjoy my career. No, it's okay. But in my I honestly, in my first year or two of OcRehab, I didn't it wasn't an enjoyable job for me. That's why in my early years, I only did 4 days a week doing OusRehab, and then Friday and Saturday, I normally did treatment. Like I was working at a clinic in South Mentwithville. So I always had to keep my passion alive. And at that time, my passion was treatment. Nowadays, though, obviously, like with experience and stuff, you learn how to talk to people. You learn, like you get referrals from every form of life. You get them from solicitors, you get them from case managers, you get them from employers, whatever, injured workers, word of mouth. And this is both treatment and OusRehab. So it's like it all combines. But then with my early career, I felt like when I was at the case conference, like with the doctor, I was just sitting there to warm up a chair. Like I didn't see
this is where you're an EP or
no rehab consultant.
rehab consultant. Okay.
Yeah. So like I just didn't see the value in me being at certain appointments, and I was too inexperienced to understand it. And obviously everyone's got KPIs and stuff, especially when you work full time. But then now in my senior years, when I go to these case conferences, I know who the doctors are, I know who the specialists are, I know who the physio is because I spoke to them before I got there, or I've already got a report from them. So then when I'm there, I'm adding value to the claim. So there will be a lot of appointments that I'll be like, hey, you've been unwell, injured worker, you haven't seen the physio in a month. So there's like, I'm not expecting an upgrade unless you need me there. Like my injured workers are like, hey, John, I like really like you at this appointment. That's entirely different. So them thinking, oh, John's here. Like it's completely different because they think that you've got an agenda that is just to force them to get back to work. But with my patients and with my injured workers, it's like, hey, we'll worry about the work component when we get to it. And it could be immediately, it could be 6 months down the track, but we need to work on returning to life first. And then you can focus on all the other noise.
You have no idea how much I agree with that, because I think that's, my entire company's philosophy is based on that, specifically just based on that. Like, get people better first instead of just pushing them back to work. Like, I think, one of the reasons why I never put it on record is that the reason why I started this company is because I've seen the worst of the worst. Like before, we were doing a lot of work in terms of medical legal work for insurance companies to essentially everyone can go back to work. And then I do see a lot of how should I say this, dodgy claims that going all the way to settlement. But there are also a few, and if I had to guess, it would be like maybe like 60-40, so like 60 dodgy claims at the end, and then 40 that genuinely can't do any work at the end. But the insurance company, without essentially a paintbrush over it, saying all of them, I want them to I want you to certify them, not me, but like the assessors that that were doing it, like essentially for certify them for full-time work, so that our settlement is less. And I was like, that's probably not work that I want to do. I want to actually help people. Right. I want to help these people get back to work, hopefully get back to a life. And I do think Australia is struggling with the amount of workforce that we have, because we do have a very small population, and then having people off work is probably not the best idea. So my entire idea was get people back to work. Get people better and then go back to work. And that's what started this company. And then it seems like it actually works. I mean, like, hey, like when people are back healthy, they do want to work.
Yeah, of course.
Like big majority, I would say like 90-95% of people actually do want to go back to work. The ones that are dodgy, the funny thing is they actually don't stay with this company much, because we will still push them back to work. It's just that not at the not at a stage where we think as impartial as we can that they're not fit yet, right? But once they are fit, we'll help them go back to work. And I don't know, it's one of the greatest things that actually happened in my life.
Absolutely, and it shows. It's good.
No. Anyways, it's about you. So I want to talk about you. But okay, so EP and Chiro, it's a cool overlap, and I don't think many people are like you, where you have the experience as an EP and then rehab consultant or rehab, and then went back to Chiro as well. So how did you, at what point did you decide, or what reasons did you decide to go into rehab, and what reason kind of you took to get out of it?
So like the way that I explain it to most of my patients is that AusRehab pays my bills. And then treatment, I do it because of passion.
Okay.
So, and it's bizarre. Like I never understood that sitting next to someone at their doctor's appointment, I'm getting like, or the company's getting paid more than the physio helping them, which is fine because everyone's got, like the way that I see it now is all my injured workers under AusRehab, they're my responsibility. So if they're not getting better, the insurer or whoever is going to point the finger at me saying, hey, you never sent us that request. You never spoke to the physio and made sure that they were doing things correctly. So it's like a damage pay, I think, or a danger pay. So with me doing EP initially, it was really hard to get started 15 years ago. Like I'd go to doctors or meetings with GPs and stuff and thinking that they'll refer to me and all this and everyone's going to be a best friend after. We'd go to these appointments, shout lunch for the doctors, like the whole office. I'd be explaining to them what an EP does and
it doesn't work.
No, it doesn't.
No, it doesn't work. 15 years ago, that's essentially when I think, if I'm not mistaken, like peak condition, that's when they first came out.
Yeah,
and that was like the biggest one back then.
Yeah.
But,
and then shortly after, I think like Guardian, I don't know when they started, but they're one of the leaders, I guess, because they've solely got EPs, which is awesome. Like they're fighting the good fight, I think, with that. But so I eventually got into AusRehab to sort of understand the whole system. So it was actually my brother that
so
told
it's like
me.
you're like a spy into an AusRehab system.
Kinda, but I honestly encourage any health like treatment provider to try and go across the ditch kind of thing. Like because you're going to know how to work a system so much better if you understand all the moving parts. And I feel like without that part of it, like AusRehab has taught me so much and made me a better practitioner. Because like you'd go to a doctor's appointment and let's say there's an EP working on a file and they're not getting results. All I need to think of the end of that is, okay, I won't do things the way that they did and then I'll have a better outcome. So you learn from other people's mistakes. You learn from other people's journeys, definitely. And that's probably why I'm here too. But I was constantly challenging myself and especially like butting heads with GPs and stuff. Like an EP is not even in the same realm as that. But then to be able to coordinate yourself and be able to find common ground with the GP and say, hey, but I'm here to help. Like this person's potentially addicted to opioids and we need to like put them through rehab and get them off it because they need a return to life. And you get like, it's like those Band-Aid solutions. And I feel like in terms of practitioners as well, a lot of practitioners do the Band-Aid solution. Like for example, like chiros with the pain release, but they won't tell the patient, hey, this is only going to last like a day kind of thing. But then when you're talking about the exercise stuff, it's like you could go for a walk today and still be burning off the calories for another 2 days. Like that's well known. It's like 24 to 48 hours, you're still going to be recovering from that walk. And like the research is so prominent with it and the research is so strong. But then with something like chiro, you're trying to tell, like a lot of the unis are putting great work through for chiro. Most of it's coming from America, but there's definitely a lot coming in Australia that's sort of like rebranding chiros, I think. But in terms of that, you're almost asking a chiro to say, hey, can you go sell your yacht and put that money towards research? No one's going to do it. So they're gonna be like, no, I earned that yacht. Like I want to go out in it, which is fine. Like I completely get it. But whereas with physio, it's like because their scope is so large, they can take research from every pot, which is fine. Like they should because it works. And then with the chiro approach, like ideally it's evidence-based. But then you're going to like experience pays a lot too.
So is that the reason why you jumped from AusRehab back to into chiro?
Well, I'm still like, so currently I'm still doing AusRehab just because I've like,
paying the bills.
I've like worked way too hard in it to like let my networks go and let my passion go. So over the years, once I sort of defined AusRehab for myself, like so at the beginning it was like an employer that wasn't fantastic, but I was there for a couple of years. But they were sort of telling me what their goals are, and those goals had to be my goals. But now that it's like fast forward 10 plus years, my goals are my goals. And with my injured workers, like I've got this relationship with them that they know that I'm like in their corner kind of thing. Like if the case manager does something wrong, like a oversight, then I'll pull them up on it. If the injured worker's not pulling their weight, I'll pull them up on it. I tell them at the beginning, I'm like, unfortunately, I'm not here to make friends.
Oh, gee, do you want a job here?
It's all good. We'll talk about that later. But
that's pretty much how I think as well. Like we have to call out all sides of the story because it's not one side that's wrong or one side that's right. Because I always, I wouldn't say a lot, but like I would see injured workers doing the questionable things a lot. right? I also see the employers doing a lot of questionable stuff. And I also see doctors and insurers doing exactly the same, right? And some part of it might be knowledge, as in like they don't know what they're doing.
Yeah.
But a lot of times, I don't know, not a lot of times, like majority of the times it is knowledge. Sometimes it's, a small amount. It is, just pretty like, pulling.
But I think that could potentially be like a group shortcoming where no one's educated the employer on what to expect. No one's educated the case manager on what to expect. Because it's really easy to be sort of naive with health and be like, okay, two guys have the same back injury, same segment, doesn't matter. This guy got back to work after, let's say, 6 weeks to be realistic, and this one's still off work 6 months later. So the employer, if they've got both injured workers, they're going to be, why is old mate slacking behind? So it's the injured worker's fault. Not that the injured worker might be seeing a different physio, might be not getting physio, might be getting advice from his doctor saying, hey, just don't move. Whereas the other physio for the other injured worker is like, no, you need to keep walking. Like movement is key to getting better. Like don't sit around and do nothing. Don't put a cast on it when you need to be moving the limb or whatever it is. So like in saying that, with my injured workers, I tell them, because a lot of them are in the trades and stuff, and a lot of them like work in warehouses. Like as much as people might want admin roles, there's only so many admin roles out there. So the way that I explain it to doctors, especially when they're a bit reluctant to put capacity on a certificate, is we need to pretend that this worker is going back to an admin role as if you would tell that person that they can't do it. Like there's no way. Like most people, like even if they broke their leg today, the only difference that would make is that tomorrow they'd be coming with crutches and maybe a cast on their leg. Like it sucks, but they can still do the job. You just got to mitigate their pain response so that they're not living in total like misery. And then you got to make the place like accessible for them and safe for them to work in. And it needs to be like manageable. So with that, because a lot of injured workers, especially if they work in warehouses and stuff, the doctor obviously cares about their patient, but they're almost shooting the patient in the leg because they're stopping them from returning to work. So that means that they're going to lose contact with their mates there. That means like they're going to be so detached from the workplace. And the way that I explain it is like when I was younger, like if we had the 6-week holiday for school, learning or knowing that school's next week and on Monday, I'm like, oh, I don't want to go to school.
You
like,
dread it.
Yeah. You know, like because you're used to staying up late, you're used to playing games all day, and you know that as soon as school starts, mom's going to take the TV off me, whatever. Yeah. So you end up dreading that day. And the longer someone is away from work, the more they're going to dread that day. And then they're going to be like, actually, I don't necessarily want to go back. And then we've either got to find them a job somewhere else, which is still nerve-wracking, or like it just destroys certain relationships. And that's not what you want either. You want them to maintain that relationship and say, hey guys, accidents happen, injuries happen, no one's fault. And we're just going to all pull our weight and try and get to the end goal, which is getting this person back to normality, like potentially as close to 100%, if not more. So like with the EP approach, if someone's like weight limit is like 20 kilos, EPs generally, if they're sort of well versed with the system and know what they can sort of where they can move in it, is EPs would generally shoot for 30 or 40 kilos of safe lifting, because chances are if the person can do 40 kilos, they can definitely do 20. But then you see the other side of the fence where most back injuries happen in like a workplace because someone's gone to pick up a stapler. Their body thinks, oh, this is like only a few grams, but then the body hasn't braced the core, and then that's where the disc goes, or that's where the muscle gets pulled because the person wasn't expecting there to be their body weight that they're picking back up. So it's like it's the whole mechanism behind it. So if someone's like picking up a box in a warehouse, the box all around it says heavy. So the person generally is going to know, okay, like when I reach down, I need to brace my core, I need to pick it up. So like warehouse workers are generally so much stronger than office-based workers because we get sedentary, we get lazy, and our muscles do too.
Absolutely.
Yeah. No, I can speak for that too. Yeah.
No, okay, that's cool. Then in terms of chiro, like, what do you, what's your like day-to-day like in your chiro treatments?
I guess my business model for EP was to be mobile. So, because like there's plenty of people that work in clinics and stuff.
Oh, you're like a mobile EP that travels around. Okay,
so
cool.
Then it used to annoy me when I potentially couldn't meet up with a patient at a gym or something. So then I learned early on, no, like as an EP, I can travel, I can move. So I ended up meeting patients at gyms, parks, wherever, their house. I sort of adapted that model to chiro. So with chiro, I'm taking my bed to their houses or wherever they want to meet me, kind of thing.
How? Sorry.
It's
do you put it in a ute or something?
Yeah, I've actually got a ute, but it's a portable bed. Like the Mickey Mouse of beds that I've got, like the awesome one, it weighs like 25 kilos and I've got a bag for it. So I'm like almost breaking my own back just taking it in and out. I do have some lighter beds, but that one's got all the bells and whistles. And then I just set it up in like their living room or wherever and do treatment. But most of it, like with the chiro approach, I don't necessarily adjust everyone either. So if they're like, I'll tell the case manager straight up, this person's contraindicated to adjustments. That doesn't mean the chiro down the road might not adjust them. But I'm just not going to because like potentially there's a warning that like they're osteoporotic or something, or they've got like some inflammatory issue, or it's just the risk doesn't outweigh the benefits for me personally. And there's plenty of chiros that possibly would adjust someone that I've contraindicated. But I just like to err on like the safer sort of side where less risk and more reward kind of thing. So I do, with chiro, I do home visits as well at the moment. Yeah, till like my body can't handle it anymore. We'll see how many years or months I've got ahead of me.
You can carry the 25 kilo bed. Then, okay, I think a lot of people have this exact question. What's the difference between a chiro and osteo?
Okay, so if we're looking at like definitions, like if you Google something, osteos generally are more holistic. Like they look at the body as a whole. Chiros are meant to be that they see everything stemming from the spine, right? But then when I studied it at like a university in Sydney, I feel like based on what I know about the whole industry, based on what I like my mates that are osteos and my mates that are chiros, I feel like the newer age chiro is an osteo, but just called a chiropractor. So because newer age chiros and especially if like a chiro from 10 years ago wants to get retraining or do courses, because we've got to do courses every year. So they're probably aware of this anyway. But chiros these days are holistic and we look at all the limbs. It's like, so if someone comes with a wrist injury, a chiro is not going to turn them away. They're going to be like, yeah, like that's definitely within my scope. And then with x-rays and imaging and stuff, like chiros are definitely on top of it. So one thought process is that osteos are more in tune with like nerves and stuff. But then I feel like chiros are just as much, like with mobility and the movement of certain segments and then what that means for the body.
It seems like, you can't have one without the other.
Yeah. So again, like if you go 5-10 years out of uni, everyone's going to overlap. Like it's just natural. So yeah, like chiros and osteos, you wouldn't be able to tell the difference with two that are experienced.
Basically, you're saying they're pretty much the same thing.
Yeah.
Oh.
Yeah.
Okay. I'm trying to process it because if they're the same thing, why do we still name it differently?
I don't know.
Convention.
Like
maybe?
in America, I think there's a bigger difference with them.
Well,
like,
what's the American system?
So with the American system, osteos, chiros, and medical doctors are seen on the same level. So like in America and Canada, I believe, chiros and osteos can refer for MRIs. They can refer for everything and it's included on their patient's private health or whatever. But in Australia, we're very dictated by a certain scope. So like in Australia, chiros, if you want Medicare to pay for the scan, you can only do 2 or 3 spinal segments. And that's it. Like, so I can still write the referral for a wrist injury, but then the person would pay out of pocket. So what I've done in those situations is I've written the referral for them and said, hey, go get your doctor to copy exactly this. And then they get the GP to write the referral and then it's Medicare covered. So there's ways around it. But it used to even save money when there was gaps for people when there were gaps for people to pay to go see their doctors. Now that's changed back to what it was. But when there were gaps, it was probably still cheaper for the person to take my referral, pay out of pocket for the x-ray instead of paying again to see their GP and then get the referral and go. So, yeah, if there's not one way, there's another.
Interesting. And where does physios fit into that picture then?
So I think in the general day-to-day, physios are normally more attuned with rehab. So it's not necessarily frustrating, but like an issue that I've got with the whole industry is that like some practitioners will just sit on their patients in terms of just keeping them for way too long at the patient's detriment. So in like early on when I went to this seminar with a highly experienced exercise physiologist running it, and he was trying to change the way in the direction of CIRA because at one stage, not sure if it was ever going to happen, but CIRA was on the fence about letting EP stay on the system or not. This is like a few years back. So it feels like yesterday. Since then, like EPs have generally shown their value. But he was basically saying that unfortunately injuries are always going to happen. Like it's just a way of life. So if you discharge a patient, another one's going to replace them. Like especially if you're half good. Like I feel like especially for physio, you don't need to be like a high achiever. Like it's great if you are because you can diagnose, you can do everything, but it's not I don't know if this is like naive, but I feel like the acute systems, they're not rocket science. Like if someone's in pain, anyone can almost figure out where it's coming from, unless it's like deeper, and then scans can find that out for you, and doctors and specialists, like there's a whole team that can assist you. And then if you find what the problem is, you find out how the problem happened, how to prevent it, and then you're good. So with physios, I feel like they're umbrella on everything, which is a fantastic thing. Like I've got so much respect for all sort of walks of life. But it's just if a physio is able to discharge to potentially like a strengthening program from an EP, then the physio will free up their books for another patient to replace them that's in acute pain. Like there's nothing wrong with that. But it's when the physio sort of balances on the side of maybe outside their scope, or maybe if, like the way I see things is if there's a chance that someone's better at something than me, why wouldn't I send it to them? Like instead of like, I'm happy to learn whatever, but if it's definitely outside my scope, then have it. Like if it's going to be a better outcome for the person, because at the end of the day, especially with the way rehab is that if physio fails, EP fails, chiro fails, the person's probably going to get surgery depending what it is. So
that is true, yeah.
What I speak to like a few of the practitioners that I work with is as long as you're happy at night, that you can sleep knowing that you've done everything you could for that patient, not that you're holding on to them too long, knowing that it's going to be a negative impact for them, then go to sleep happy.
Yeah, no, I think that touches a very sensitive point, because I think, incentive runs the world, right?
Yeah.
If they keep the patient, technically they get paid more. Pretty much that's with everyone, right?
Yeah.
I'm actually, with you on that point as well. Like if you're doing a good job, chances are people are going to come back anyways. Why do you need to, hold on to them for more longer than necessary? And if you're not doing a good job and the person is not recovering, maybe, another alternative route might be the best way.
Yeah, absolutely.
Huh, that's weird. But okay, that's cool. Pain and recovery timelines people get wrong. So I think that touches on another point, which is, why are people getting pain and recovery timelines wrong? Meaning, sometimes pain lasts a lot longer than it needs to be. Like, what's gone wrong there?
So the way that I see realistic recovery is potentially different to textbook recovery. So in journal articles and evidence-based practice, that sort of thing, the timelines that I've come up with are normally in as perfect of a condition as you can get. So like the participants in the study, they were told, like, there's a few chiropractic ones which I think are humorous, but the people were told, hey, don't exercise. We purely just want
this is like an actual study.
Yeah.
Okay,
like there's a few of them where they just want the patient or the person with that problem, they only want them to be exposed to chiro treatment, which is in the definition of chiro treatment, it's adjustments like high velocity, low amplitude adjustments, generally speaking. But how is the person not walking from the car to their house or going to the shops, that sort of thing? So it's really hard to police that, whereas the person's like accidentally doing rehab. So it's fine. But with the pain scales and that sort of thing, is that if the person is I guess not in a absolutely perfect environment, then of course they're going to have relapses. Like it's fine. It's the way of life. So like a back injury, if they turn the wrong way again because the problem hasn't necessarily fully resolved, then they might re-injure it. But I don't want that to bring fear onto people, because pain is just one factor with recovery. So there are some like models that don't even necessarily account for pain. It's like, hey, as long as the segment's moving properly, as long as the joint's moving properly, everything else will fall into place. And a lot of people have that. But then unfortunately with pain, the way that I see it is if someone truly has symptoms after the textbook deadline, I guess, then potentially the diagnosis was wrong, or potentially it needs to be looked at again. Because if you've done an MRI at the beginning and then 6 months later the person's in the exact same amount of pain, potentially the treatment methods in that 6 months were incorrect, or the problem itself was either misdiagnosed or it developed into something else. It can happen. So that's where I encourage people to keep, because with scans, it's all objective data. Yeah. So it helps to sort of find out where the system's lacking or where the person's not getting the attention that they need. But that's like, and then we haven't even started with like the mental health side of things. Like if someone's going through depression, anxiety, their marriage breakdown because they can't be a breadwinner anymore. Like there's so many other factors involved. Like no one would be able to go to sleep if they're stressed. The body keeps people up, and then people call that like insomnia. But it's generally when the body's not at balance, it's not at peace. So of course there's going to be all these variables affecting that person's pain. Like if someone gets better quicker, maybe they had better sleep. Like that could have been the only variable that changed. So with my role as practitioner and rehab consultant, I'm trying to always look at things from every angle. Like with most of my appointments, as long as the person's happy with it, I'm like, hey, bring a friend, bring a family member. Because when people see, like, it's a different story, but it's like when I go do worksite visit, right? If someone's injured and the workplace and the guys in the warehouse, they all see me arrive to the worksite, they're going to be like, oh, that's not a good thing. Jack must really be injured. And then they take Jack seriously instead of like teasing him or bullying him about his injury. So sometimes like us turning up to site, even as a treatment provider, like if I do EP sessions at the guy's workplace, like that's happened before.
No way.
Yeah, but it's sort of like you do it sort of to show people that, hey, this person's suffering from something real. Give them respect kind of thing. And then just like there's no need to throw names and treat people differently just because they've been unlucky enough to suffer from an injury.
That's a new perspective I've never heard of. Like I'd actually never thought about this. Like so showing up at the workplace looking serious actually makes them
like it validates it a bit more, I think. Like yeah.
That's interesting.
And it's the same with, like, as long as everyone's okay with it, but it's the same as getting the employer to go with them to the case conference. Like, I'm all, like, as long as the injured worker and I guess the GP are happy with it, I'm like, bring your mates. Like, it doesn't matter. Because, like, as long as this is above board, everyone's going to understand where the person's at. No one's going to put unnecessary pressure because they understand where the person's at. I take the responsibility and say, hey, this is where the injured worker's at now. This is where we need them to get, and this is the pathway to get there. And we need everyone to pull their weight in it.
I'm actually thinking about something completely different.
Yeah.
Like it might even be a marriage counseling kind of thing. So imagine, you doing treatment and then, the guy or the girl invites their boyfriend, girlfriend, husband, wife and go, hey, actually look at me getting treated. Yeah. And then, you potentially might stop the nagging of
absolutely.
doing dishes and all that other stuff.
For sure.
That's pretty cool.
Because they understand that it's real. Yeah. And like, I guess in this scenario too, like some of my injured workers, they'll tell me at the beginning of their claim that they've got like nerve pain down their arm. But then the person just by accident forgets about it and forgets to report it because they don't want to like annoy anyone. And I'm like, hey, about that nerve pain, do you still have it? And they're like, yeah. And I'm like, great, keep telling me this because I need a paper trail. So if anything ever develops from this, it's something that you haven't made up. It's something that's been there potentially the whole time or developed into, but you've let us know straight away. And then the person can get the treatment from that. So it's not like this person hurt their elbow, their shoulder starts hurting and the insurer doesn't want to support the shoulder. But it's like, if you look at the mechanism of injury, it's like, it seems reasonable that would happen. But getting like the IPCs and stuff to understand that and the IMSs, sometimes that can be a bit tricky if they're like sort of denying the claim or denying that it's progressed into something.
Yeah, I think that's a rehab consultant job, though, in my opinion, because we're supposed to be like, we're literally supposed to be the people that are like the mediators in the middle, that shares information to the entire, or literally every single stakeholder to make sure that everyone knows exactly what's going on. And if we don't report on it, then you're probably not going to get the right treatments. Or being misdiagnosed or anything,
or having unnecessary surgeries.
That's interesting. Anyways, going back to the your OusRehab life, because I find that fascinating. Like we were talking, beforehand, that you used to work. Was it during OusRehab that you did a bunch of drug tests? Or
Yeah. So at one stage, like it's funny because in my family, my parents were basically saying, while you're young, work till you die kind of thing, like just do the grind, don't worry. So the hours that I was doing at this particular job, this is the Monday to Friday job that I was telling you about, I think off air. And then the Friday, Saturday was treatment. So I was working like, I was a dog. So I'd have drug and alcohol testing at like 4 a.m. at like a truck depot somewhere. And then I'd still have case conferences at like 8 a.m. in Campbelltown or something. And I was just all around Sydney. I was exhausted. Like there were so many opportunities that I had micro sleeps. I had the whole thing. Like I was just running on fumes. But the drug and alcohol side of things, that was so interesting too, because coming from an OC rehab background, I was able to sort of guide the worker or the test, like the subject, into what their rights are, kind of thing. So under like WorkSafe New South Wales, if someone does test non-negative, like we can't, even if we go to a site and test them and it shows up in the cup or the saliva sample, even if it shows up positive, we can't call it positive because it hasn't been lab tested. So we like legally have to call it non-negative. And then we eventually get another sample if it shows the same, because we can always say the cup was faulty or the sample was faulty. We get another one if it's the same picture, then we do a third sample, and then there's a whole thing with chain of custody. So it's like, it's funny, but that urine sample is now my property. And I personally have to go deliver it to the drug and alcohol lab. And then that person has to sign it off from me. And then whoever else touches it in that lab has to sign it off. So it might go through like 2 or 3 hands before it actually gets tested. Then when we get it back from them, they will tell us it's positive for whatever. But the cool thing is that it doesn't just stop there, because if the person, normally we have to put their excuse or the reason that they think that it might be in their system. Yeah. So someone would literally say like, oh, I had cough syrup. And I'm like, okay. And even if I know in my head, oh, that's probably unlikely, I've got to write it down because like duty of care and everything else. So then when the labs get back to us, they'll say it's positive for this whatever, normally found in, and it'll be what the guy said. Like, so it's wild. Like, so they're that specific that they know that this potential chemical that may show up positive in a drug test is from like something off the shelf at Woolworths or whatever. Like, it's that side of it was really cool, because then it changed my judgment. And I'm like, because the guy might have looked like he was on something, or I assumed that he was, and especially like testing 2 samples already and it's non-negative on both, it's a high chance that they're on something. But then when their story sort of plays out, and it you're
matches.
like, yeah, and you're like, wow, I had no idea. Like, so with that particular job though, luckily I'm tall, because it did definitely get me out of a lot of tricky situations where people, I completely get it, but like imagine like, going to a truck depot and you've got to wake everyone up at 4, and like one of the drivers got there at 1:30 and is completely wrecked. So we used to do like, I call them halfway houses. I'm sure they got a different name, but it's like if the truck driver, right? Like if the truck drivers got to do like a stint from like Brisbane to Melbourne, they may stop in Sydney, kind of thing. Like it's like half, that's what I call halfway house. Right. So it'd be like a normal residential looking house, but you see all these like trucks without their cargo because they parked them off somewhere else. And so it's like that's sort of like their taxi service that they've brought and parked there. And then we'd have to wake them up. So of course you're going to annoy a lot of people by waking them up at 4 or 5 in the morning.
Is there a reason why you go at 4?
Yeah, so everyone's there. Yeah, because you don't want people to like sort of get out of there. And normally like they have to sleep they have to rest a certain amount of hours before they're allowed to go off again. And like even
waking them up in the middle of the night, that kind of, signals that they didn't rest enough.
No, not at all. But like surprisingly people, once I explained the situation, I'm like, I'm so sorry, it's my job. I don't like it either. Like, like I don't like this part of it, that I've got to make your life miserable for like an hour. They were generally really fine because they knew what their obligations were.
Well, it takes an hour to do a drug test.
No, like if you're going to do the whole house, you're not there. Like you're not in and out in like 2 minutes. You'd be there for a bit, and because you got to put everyone separate, you got to read them their rights, kind of like that's what like you got to sort of explain what you're doing, and it has to be really clear, and they've got to understand it first, and then you do the drugs, the test, and if there's any issues with it, that's obviously going to take longer. Like I had this one that a guy on a site, like a truck driver, because he was still on site, he was drinking like a bourbon and Coke or something, but he was washing his truck. But because he was there, I had to alcohol test him, and then because he blew positive, the workplace ended up intervening. So we don't generally follow it through, but like we sort of are there for the sort of the trouble part of it, but we don't get told what the outcome was, obviously, because we just
do you actually know, like, or guess what the outcome might be?
Like even if the person had an issue with drugs or alcohol, generally, like in New South Wales, in Australia, it's the workplace's obligation to give, like, to offer them rehab. Like they obviously don't have to take it, but then disciplinary action can come through if they fail to like meet their criteria. So like let's say you had someone that tested non-negative, and then the lab showed that it was something positive, like an opioid or something like that, or amphetamines, methamphetamines, THC. If they were positive, they would have to put them on a rehab plan. So we would actually go unannounced like every couple of weeks and test them. And we would say, hey, in the next 6 months, you're not going to know when, but we're going to come 6 times. So it would hopefully be motivation for the person to stay clean. But then if someone's truly got a problem, it's like, it's hard to blame someone for their mistakes when like things can be addictive. Things like they can feel powerless and they need certain substances to, like obviously people can have ill intent for doing drugs and stuff like that. But in this situation, if someone's just like misunderstood and they're calling out for help, then that's part of it too. It's like, hey, if you really need rehab, then we'll get you there. Because everyone deserves to be able to put a like roof over their heads.
I actually have a slight different opinion of it. Like if you're working and you're responsible for segment of the company's work, I do think people have the obligation to
be safe,
be safe and to do the work at the best of their abilities. And addiction, yes, it's harmful, it is bad, but I do think most people if they put their mind to it, should be able to get off it. I don't know. I've never been addicted to anything.
Well, I had, speaking of that, I had like when I was doing pre-employments like some years ago, like the applicant would know that I'm going to do a pre-employment check in like 2 weeks, and they would know that there's a drug and alcohol component. And this one guy that I had come, he was such a nice guy. His eyes were bloodshot. He seemed a bit off. And then I asked him, I'm like, hey, before I get you to pee into the cup, is there anything you need to tell me? And he goes, he ended up disclosing that, and this is before medical marijuana was a thing. It was before that, so it was still like illegal. He told me that his grandmother smoked medicinal marijuana and he hangs out in the same room as her. And then because I don't know because I used to always get my friends ask me like, oh, how long does it stay in your system? And I'm like, I don't know. Like there's so many variables to it. And I'm not someone that did any of that especially because one of my managers, if anyone contested the cup working or not, she'd be like, oh, don't worry, John will go do one now. And I'm like, you've just volunteered me. Like I felt so like I was never doing anything, but I felt so uncomfortable being put on the spot that I was getting drug tested as well indirectly because she's offered for me to. It was really bizarre. So that's like the political side of it. But it was funny. Like I didn't care because I'd go do my sample and it would always come back negative. Like I never had an issue. And then I'd prove to them, obviously the cup's working then. So with this particular individual, like I had to write on the sheet because he tested positive to THC, or non-negative. So I had to write on the sheet that he hangs out with his grandmother that smokes medicinal marijuana. And then when it got back from the lab, they were surprised that he walked into the appointment because he was that stoned that they don't know how he got there. I'm like, I don't know. Yeah.
What?
So it's proper. Like it's like, but sometimes like this guy was unemployed, but it's like it's not a good reflection on him if he turns up to the pre-employment after 2 weeks' notice. And he definitely wasn't the only one that did that. Like a lot of them, so that's why I'm like, he had all the warning signs. He had like in this case, he knew that he needed to be clean.
Weeks.
Yeah,
and
he was
2 weeks to get sober, essentially.
Yeah, and he was like stoned as. Yeah.
God.
So like you obviously test their blood pressure and stuff and you're like, oh, I don't know if it's safe to put this person through the paces because I don't want him to have a heart attack in front of me.
Gee. Any other cool stories in pre-employment?
Yeah, there's plenty. I had this one guy, so I can't name any names, obviously.
No, absolutely don't name any names. Not even the company names, nothing like that. No.
So I had this one guy that I was doing a pre-employment check for, similar sort of thing, but it turns out he was out of prison 2 weeks before that. And he turns up and he's wearing the baggiest hoodie. So he wasn't a big guy, but he was wearing this hoodie that might have made him seem like he was big. And then, so in the early onset of that assessment, this is back in the day, I could have done it digitally, but I chose to do it on paper. And then I used to convert all my notes to digital.
Is it old school? Huh?
Yeah. So I had this stack of documents. It's like a 10-page pre-employment check. So I had these documents and all I got at the beginning of the assessment was I got the gentleman to stand up and then bend down and touch his toes. As he did that, in the corner of my eye, a shiv has fallen out of his pocket. So a sharpened spoon or something. Like it looked like a toothbrush and it was like turned into a knife. It's like why anyway? So that was plan A. And then that's why I said like my size has gotten me out of so much trouble. So I ended up like shifting my documents over, pretended I didn't see it. And then I just messaged my manager saying, hey, under no circumstances are you to come into this room because like things are happening. And then he ended up, it was like it didn't stop there with that individual because he ended up like when he produced a sample of like urine, like normally we're meant to follow him in to the bathroom, right? And then technically I think we're still like with their consent, we're meant to like somewhat be in earshot or eye shot of them giving the sample. But I used to just go check and I used to like lift the cistern to make sure they haven't like tampered with anything previously. And then I'd just stand within earshot. And this guy, when he gave me the cup back, it's funny because the cups that we had, they had temperature on them and they had the pH. And it was like condensation on it.
I know exactly what you're talking about. Because I've seen those as well.
Yeah, absolutely.
People try to do it.
Yeah.
Like they bring a little bottle. And
Or the bladder bag. Yeah. And then so the funniest thing is that this guy looked like he was taking everything. And then when he gave me the sample, it was obviously cold. So I'm like, hey, unfortunately, I can't accept this because the temperature and the pH has died. Like, so the sample was dead. I'm like, we're going to need another sample. And he goes, oh, I only pee like once every 2 days. I can take it home and bring it back tomorrow. I'm like, unfortunately, I can't wait for that. And the funny thing is that sample that he gave me, I don't know if he bought it off one of his mates or if he bought it online, whatever, but it was non-negative to amphetamines and methamphetamines. So it was proper. Yeah. So it was a proper sample. And then he refused to give me another sample. So I had to split that sample up into the like the chain of custody, like when you're not like necessarily meant to. But then again, I don't know what happened. Obviously my advice was don't give this guy a job, but I don't know what happened after that.
No, it actually reminds me of an incident that we had here as well. I don't know how much I can say it, but essentially, same thing happened, right? Like we're curious. We kind of like say, hey, give us a second sample so we can somewhat test it. The bloke, from what I heard, because I wasn't doing it, one of my employees were doing it. Like sat here for like 2-3 hours, couldn't piss. Yeah, look, I don't know whether he was, not negative.
Yeah,
I didn't know.
Like just holding back.
But sat here for like 2-3 hours and then couldn't.
I know, like I personally get stage fright. Like I'd have to chug liters of water to be able to give a sample, but that's just me, and I think it's because of all the tubes that I've got. So I don't know, maybe. Yeah,
that's cool, but that's pretty damn cool. And okay, any other cool stories in pre-employment at all? Drug test pre-employment? Because I do feel that, I've got a fairly funny ones as well.
Yeah. Like we had this one, it was at like Oran Park before it was like built up and stuff. So it broke my heart, but it's when they got rid of the racetrack. So this is a fair few years ago.
And we got to say that racetrack was decent. It was cheap as well. Decent and cheap.
Yeah.
I don't know why they got rid of it.
Yeah, I know.
It's like, $50 or something to get in.
It's devastating.
Like now you go to a track day, it's like $400. Minimum $400. Yeah, anyways.
Are you a petrol head?
A little bit.
Oh, cool. Okay. We should have spoken about cars then.
We should.
So there was one that we had at Oran Park, and like there was this truck driver. He looked like he was driving like a sort of like not a garbage truck, but just like a dumpster where they'd like lift the soil and put it in the back of his truck. It wasn't that big, but the guy so this is when whatever the policy is that we had, like police would have gone to the site potentially, depending on the severity of it. But then we, as a third party, would go there and test everyone or whoever was involved in this situation.
So the employer got you guys to
so the
company did it.
So we had like whatever the contract was with them, that we were there like first responders kind of thing. So we would go out to the site and just like liability wise, we'd sort of take the hit, which is fine. Like we'd go there and say, hey, we came at this time, the incident was told like it happened at this time, whatever. So we have to log everything. It's like a event log kind of thing.
Hold on, you were there before the cops?
Like occasionally, yeah. But then they'd probably go there and just get the same story we got. Like it depends if it was like road and.
I'm thinking like if that happens, they have to pee twice. within like the
Yeah,
space of like a few
potentially.
hours.
But
Like,
then
how?
sometimes they would go off our sample though, because
okay.
we're third party. It's not like we're bullying them or anything. Like
Okay.
they're like, yeah. So I don't know. I don't know if the cops ever got their own samples, but I think now cops generally do their own drug testing. But I don't know what it was like 10 years ago. With maybe it was a different system back then. But we had this one situation where a guy driving a forklift truck, I think he was trying to move like a dumpster bin, but he ended up reversing into this truck with old mate just eating like a sandwich in the truck. So then we got there, we got both stories from both of the gentlemen, and the guy in the truck was just chilling out, eating a sandwich. We had to drug test both, but the guy eating the sandwich tested non-negative to THC. So we had to stand him down for further investigation, like implying that he's got to do another test in probably like another week or two, but he stood down for the whole time until he can produce a negative sample. But in this situation, it sort of blew my mind that he wasn't necessarily
The instigator,
active.
yeah.
It was bizarre. But then the guy driving the forklift, he was like negative, like he was fine. But then it was his like oversight, his fault. So the system, like what you said before, like you assume people, especially heavy machinery, health professionals, like whatever, you assume that everyone's safe. And you assume that, like, if you went and saw your surgeon, they're not like that's
They're not intoxicated when they're actually operating. Yeah.
Especially because of the risk associated. So you've got like crane drivers and stuff that are tested positive or non-negative, and like they're like moving heavy stuff. Like they have the capacity to kill people if they are not with it. Like their job would be hard enough as it is.
So, in your opinion, should we continue to do drug testing for, I guess, construction sites and warehouses?
I think anywhere, like obviously the higher the risk of the job and the more it can influence people. So it's been proven that if people are clean, then they're going to be more productive. It's been proven that like their judgment is going to be better because they're not influenced by anything. Like that's the whole, like the word. So I think anyone that has this is where it gets even more political though, because like if you've got a factory that happens to have a warehouse, why are the office workers maybe not tested? Like everyone should be painted with the same brush. So we've gone out to sites, and because people can say that we're targeting them when we go out to certain sites, like it depends. But we've got choices. We can either, if someone is properly suspected of being on something, we're allowed to test them individually. But then they can potentially turn around and say, hey, you targeted me, you bullied me, whatever.
So that becomes like a side claim on workplace bullying.
Yeah.
Okay.
So then the other options are that you do a randomized testing of the whole site. So you'd get like a record of who's there. So like let's say there's 50 people on site. You've got to use a random number generator with a verified algorithm. And then you have to actually put all of this into your report and say that it picked like number one and that is associated with this worker. It picked number whatever. So that if anyone's overlooking, it's such a fair system that you've used. Or the alternative, but it gets expensive for the employers to do a blanket testing, because some places, depending on what they are, like especially if they're office workers, they might, and this is like a bit, I don't know, out there, but they deliberately wouldn't want certain workers to get tested because they know that they're going to lose half their workforce. So like some industries are that prevalent with like...
So my jaw's just dropped. Half their workers.
Yeah, easily. Like heaps of workplaces, like sometimes Friday night drinks or whatever can turn into more than just drinks. But
well, that's fair enough.
Yeah. So like if it shows up on their systems on Monday, then what? You're going to stand down like half their workers. So they're going to plead like ignorance and say, hey, like just the warehouse today or something. But then when we'd go to site, we'd try our best, if not complete, to make it as fair as possible by doing a blanket testing across the whole site.
This is like, going to like a lot of different different topics that are very controversial.
Yeah.
Very controversial.
Yeah.
But I would think, as an employer, targeting one person might not be the worst case though, isn't? Like, yes, you might get, workplace, bullying or something, but like potentially you might get rid of a liability that's like way worse than the actual side claim that comes with it.
Like I feel like, but this is like ignorance, but I feel like it's not a hard ask to tell someone, hey, just don't be on drugs while you're at work. But then what my spiel to people, especially if they tested non-negative, I'd say something like, I'm so sorry, you've told me that you did X, Y, and Z on Saturday. I'm really sorry that it's shown up today. But if it's in your system, there's like the script we follow is that it's still influencing your decision. decisions. And if there's an accident that's going to happen on site as a consequence or an oversight, then it's like you're liable personally.
Oh yeah, no, that's another good point as well. Because if they screw up, they're going to be doubly screwed because they were saying, hey, you on drugs. Now, say there's a fatality or something.
Yeah,
They
which
might be
happens, unfortunately.
criminally liable as well.
Yeah. And then if the workplace knew that the person had an issue or something, then that's a whole nother can of worms, because potentially they may have had a blind eye to it and done nothing about it because he's a funny guy or something.
Oh God.
Who knows?
Wow.
So that's where everyone's got like responsibility for that sort of stuff.
Yeah, no,
And
No, I think, the key takeaway is, don't do drugs.
Yeah,
Basically,
absolutely.
just don't do drugs.
Yeah,
If you're working, don't do drugs. Do it when you're like, not working on unemployed.
Yeah, definitely.
God.
Yeah.
Wow. Anyways,
Yeah.
last topic I really want to talk about is military and rehab. Because I don't think there's many people that actually have experience doing what do you call it? ADF files.
Yeah.
So Australian Defence Force files.
Yeah.
And you're one of the few that were fortunate enough to actually do it. Like, what is that like? Because I actually don't know anything about this.
I absolutely loved it, and I recommend it, especially in Rehab. I recommend everyone does it. So the biggest changes that I noticed, and it's unfortunate as well, it gave me goosebumps getting to like one of the Navy sites at like 7 a.m. and seeing members jogging around and stuff. Like, it was awesome. Like, I'm civilian. I was a civilian the whole time, but they respected us so much. Like, commanding officers and stuff would be like, "Oh, just call me Joe," and I'm like, "No, like, I want to call you by your title." Like, it was unreal. And then like how family unit everyone is, like, it's wild. Like, it like gives me goosebumps remembering it. Like, unfortunately, I did like a pretty quick stint while tenders were getting changed, or I guess contracts were getting sorted. But while I was there, it blew my mind that potentially, like, it sort of made me appreciate as well, like, the financial incentives that people may or may not have to go back to work. So in terms of like the workers' comp, like civilian files, there's a lot of workers that if they're at 85% of their pre-injury earnings, they're okay with that. Like, it's not enough of a push to be like, oh, I can't afford, like, I guess now, like Sydney especially, costs are skyrocketing. So maybe now civilian work, like normal workers' comp, CTP, maybe they've got those financial incentives these days. But back like 5-10 years ago, there might not have been the same urgency to get back to work. So when I worked ADF, if they're land-based and they should be on a deployment, they're losing money. So there's...
What do you mean? Well, okay, land-based and deployment. That's like two different distinctions. Yeah, land-based means that they're in the barracks, they're in the...
Like, kind of, like, or they're just going through training. Like, until something like potentially what's happening now calls for their involvement.
Yep.
So there's constantly like training routines and stuff across the globe. So like Australia might be working with the UK or something and they do some exercise in the middle of the ocean, whatever. So if someone is missing out on being there, or if someone's been shipped back to Australia because of an injury, it could be like a broken ankle where they can't walk around the ship. So they're going to get brought back to land. When they're here, they're missing out on deployment, like financial incentives. So
are you saying they get paid more when they're deployed?
Yeah, absolutely.
Okay.
So it's like, and so they should. Like, it's an incentive for people to like actually like to serve their country.
I mean, like they are risking their lives.
Yeah, absolutely.
So it makes sense that they get paid more. Do you know how much more they get paid?
No, they used to just throw numbers around with us, but I didn't know exactly. But it was enough to get people. Like, I had members that were like walking in crutches, and they're like, "Hey, my ship leaves next week. I need to be on it." And I'm like, "Mate, mate, I'm so sorry, but it's probably not going to happen. You can't go there with an active injury or absolutely an active fracture." Like, it was, so these guys were so like, and girls definitely were so set on going back prematurely. Whereas I feel like in workers' comp, it's such a rare thing to come past where someone wants to jump the gun and go back to work. Like, most people with civilian files, they want to make sure that the physio is having a good day before they say, okay, you can go back. They want to make sure the GP's caffeinated, whatever. So there's like all these precautions in civilian files that like injured workers potentially just want to marry up so that everyone agrees that they should go back to work. Where in defence, people were going against the medical officer's opinion. They were going against a specialist, against like even the health system in defence I used to think, oh, they got a personal trainer. Like that's not even an EP, because I went in there a bit arrogant, like I was a bit young, and I'd go there thinking that a personal trainer's not going to be able to treat any of this stuff. And then you find out that the personal trainer is enlisted, so they literally go out on deployments with them, and their pure job on the ship is to do training drills. Like it's incredible. But then you talk to these personal trainers and you're like, your jaw would drop, because they are guns. Like they are so, like they would make most EPs look bad. Like they are fantastic.
How? What do you mean by making people look bad?
So knowledgeable. Like they know everything about everything. Like they are so well trained. And it's like, see, with me, it's a bit of a stab at myself, but it's like if you went and saw a dietitian and they're fat, like you'd be like, like maybe
should I even trust you?
Like practice what you preach. Like I can't talk right now because I've had some downtime, but it's that sort of thing. But these personal trainers, they were fit as anything. Like they practiced what they preached. Like they were unreal. And then because they've gone on deployments and stuff, they've gone on the ships, they've done everything that needs to be done. Their judgment is just as important as the medical officer, because they're like, hey, like it's all right. Like he can go on deployment, but I'll be with him. And then we'll keep doing our training drills on deployment, because his fracture or his sprained shoulder will be fixed in 4 weeks. Like it's wild.
I've got a question though. You mentioned that, they're more inclined to, go back to work. So go back to deployment. Is that more because of financial incentives, or do you think that's more patriotic, meaning they want to serve their country, Australia, and therefore they want to go back and
I actually hadn't thought of it like that. I reckon it's probably both. Like that's awesome. That I reckon it'd probably be a balance.
Okay,
for sure.
In terms of financials, because I think that's probably like more something you can more likely that you can estimate. Like, what's the financial benefit of going to a deployment versus just being on land and on compo?
So being naive, I think the only thing, like the changes would be that I believe once they're deployed, it's their pay is tax free. So they because they're serving the country, they don't have to pay tax on the earnings that they've got. And then like a lot of them, like let's say someone was getting a bit old, so they know that they've only got like room, or for their career, they've only got 3 deployments left or something. Like that's still a lot, even 1 deployment left, like that's huge. So they're sort of banking on that to potentially help them pay their house off or to help their kids go to school. So there's a lot. And then if they're land-based, like mental health injuries were so prevalent. Like because if someone, and it's like the way that I've spoken to some of them is I think there's potentially a fine line between someone wanting to be patriotic like for the country or for themselves. So it's like if you've got someone that was potentially a troublemaker at school and then they join the army, they just want to get out there. They just want to like do stuff, like, which is fine. Like I love them because like they're serving us. But then you've got someone that potentially is just so proud of their country. Like they're both fantastic people depending on the situation that they're in. But then you get different reasons for them wanting to go on deployments. Like if someone's like, I'm a master at a sniper or something, so why wouldn't I want to use it instead of shooting dummies or something? Like, not that it's that simple, but some people have that urgency and that calling to serve their country in every way kind of thing. And you're telling them, hey, no, you got to be land-based because your foot's a bit sore. Like some of them would be like, no, I'm going to talk to my like XO, it doesn't always work like that. And then if they're land-based, where they definitely, like every cell in their body wants to go on this deployment, then depression, anxiety, like suicide, everything is so prevalent. Like it's horrible.
Well, hold on. You're saying that depression and anxiety and all that stuff goes before deployment? Because I in my mind, I thought it was, usually they see the worst, during the deployment. Therefore, when they come back, they have all these, PTSD and stuff. You're saying that it actually happens beforehand.
So you've got both sides, right? So with part of our role was to either get people to return back to their job, which was whatever their role was in the, with me, it was primarily the Navy members that I looked after. So it was to get them back to their role. But also you've got some people that like either by choice or being forced, they'd be getting medically discharged. So in Australia, it's a real, like I think it's getting better now since I worked with the portfolio, but back then you'd have people that it's like they get forgotten. So they'd get medically discharged from ADF, ideally for the DVA to pick them up. So it'd be like almost like a handshake between us and the DVA. It's like, hey mate, you're gonna, like Frank's coming out next week, you really need to catch up with them. And then imagine if that's like my only obligation, like I'm done, like I'm cool because I've let the DVA rep know. and then that DVA rep forgets to call the guy, or like it just gets lost in translation.
It happens.
And then that person ends up homeless and they end up like it's proper. Yeah. So like there was a big, and especially like if someone's been serving like most of their life, or they're so in love with serving, and then that just gets taken away from them for whatever reason. Like some people want to be medically discharged. I get it. Like they've either got severe injuries or they've had a really bad experience where it ends up being like psychological, which is like each to their own. But then you got people that want to like they've tried everything they can to avoid getting medically discharged, and it's still gone there. Like if someone's got an amputation or something because of a bomb going off or something, like that has its own PTSD and its own sort of mental health influences. But then for that to be like career ending for them, it's devastating. So we sort of need the handover between being enlisted and then being under DVA. It's a pretty fickle sort of territory where it's like, hey, I want you to look after this person just as good as I have. Like, please do the same. And then if they get forgotten, like there's no... When I was working it, there wasn't really a durability assessment where you call a member 6 months after they've left defence and say, hey, just touching base to see how you're going. Did you end up buying that boat? Whatever. Like you don't know where they end up. And like there's a lot of organisations and stuff that like their whole thing is to help them, but of course it's going to forget certain people. But then it's one of those systems that you can probably go through the policy and find all these problems with it, but then you're like, what's the solution? Like it's not clear cut.
Wow. One question I do have, like, what's the most common injury that happens in the ADF? Sorry.
Like we honestly saw so much of everything. Like they're humans at the end of the day. Like they'll get back injuries. They'll fall from parts of the ship onto like other sections and stuff. Like there were definitely interesting ones. Like a lot of people have hearing issues because of how loud things are.
What do you mean? Like like a tinnitus or
yeah, like and then beyond. Like they've just got like so it's pretty severe tinnitus and like vertigo and stuff like that, just because of like shock waves and stuff, like explosions happening nearby. And then like even the PTSD that comes with that. Like so mental health I think was like up there. But then all the injuries were so variable.
What's the look, I usually wrap up with this question. What's the worst injury that you've seen?
I don't know. That's a really good question. I should have had some thought. I think probably like amputations. I think yeah, for whatever reason, like falling and bones are so savagely broken. But I think ADF is probably up there in terms of being the place that I've seen the worst injuries. But I think like civilian life, like there's definitely like. There's certain things, like most of them are probably like back injuries and shoulder injuries, like and neck, I think would probably be up there with civilians, but military it'd be all sorts, like shrapnel and whatever.
Jesus.
Yeah. It's
wow. No, on that note, no, thank you for coming on and sharing your knowledge and your experience. I hope the audience here actually learned something from. I certainly did. I mean, all this stuff about ADF, no idea, like. It actually existed. Well, I knew about ADF. I didn't know the back end of it. And then drug test, that was pretty funny.
Yeah, I'm glad.
Those are like cool stories.
Yeah, cool. Appreciate it.
Yeah, no. But if you guys enjoyed it, like, comment, subscribe, and I'll see you next time.